On behalf of the American Academy of Neurology and in collaboration with Neurology Today, it gives me great pleasure to introduce Dr. Gurdesh Bedi. Gurdesh and I go way back to the University of Miami days where he completed his neurology residency. He then continued on to Cleveland Clinic where he did a neuromuscular medicine fellowship. And then since then, he's really just done a tremendous job. He's been over in St. Croix, Wisconsin, St. Croix Falls actually, not too far from the American Academy of Neurology headquarters, about a 15-minute bike ride or so, and has really just taken off. He won the Kenneth Viste Physician of the Year Award from the Wisconsin Medical Society, which is also on the board. He's got a lot of all sorts of stuff. He's served on the FAAN subcommittee for medical economics and practice. I'm not going to list any more accolades, Gurdesh, but I'm very proud of you. I think you know why. But the most important thing about today is congratulations. You not only sold your house today, but it's your birthday. So thanks for joining me on your birthday, and happy birthday. It's a big milestone year for you. So thanks for joining.
Thank you. And just to add to that, I had the pleasure of having one of the best program directors in my residency program, and that happens to be Richard Isaacson.
Hey.
So thanks for setting it all up for me. The rest of it was a layup.
A layup. I don't know about that. I'll take the assist, but the great pleasure about mentoring, I've actually, believe it or not, over 120 trainees have passed on in my 12-year watch. I'm not allowed to have favorites, but.
And how old are you? You're like 31, aren't you?
I was like in my 20s when I started as a program director, but that was 12 years ago or more. So I'm retired now from program directing, but regardless, you're the wind beneath my wings. You've done awesome, and just congrats. We're all.
Well, thank you so much. Thank you.
So today we're here to talk about something that's really affecting all of us in practice. You're a solo practitioner, but the other part of you have a whole different hat that you wear. And you really oversee certain medical subspecialties within your health system. So you're not just really coming at this from a outpatient practice, private practice, solo practitioner perspective, but how is COVID-19, first of all, how has it affected you over the first 6 months of the pandemic? And then really, I guess the main question I'd love to talk to you about today is, what do you see is the short term, medium term, and the long term future of how medical practice, economics, payments, reimbursements, how a practice can survive. I'd love to talk to you about that. First of all, what is the first 6 months since COVID-19 hit? What's it been like for you?
Yeah, how much time do you have, right? So yes, the first 6 months have been challenging, but also very rewarding. I think I'll go back to March, right? Let's go back to early March. Or let's go back a couple of months before that, January and February, we kind of heard about this thing called COVID, but I don't think I paid attention. In fact, I had a trip planned to go back to India on March 14th. I remember the date very clearly. And up until March 12th, I was pretty adamant I was going to go. I thought this is, something that I could save myself from. We were wearing masks and we were washing our hands quite a lot. But again, up here in the Midwest, we hadn't really thought so much about how much of a life-changing experience this was going to end up being. And on March 12th, both India and the United States declared this to be a healthcare pandemic and a healthcare emergency, and cross-border travel locked up. And that literally was the first wake-up call for me. And that was it. And after that, in the next 4 days, I don't remember what happened between March 14th and 18th. There was hardly any sleep involved, but we shut down our clinics. We have about 7 locations and we shut down all our clinics. We changed our ER. We split our ER into a respiratory care and a non-respiratory care clinic. We did the same thing with our hospitals, created respiratory care centers, and also, protected the rest of it as the clean space, went through a lot of designations. And around March 18th and 19th, we launched our telemedicine platform, literally overnight. We had meetings starting in August 2019 up until 3 days before we shut down our clinics. We would have meetings once a month where we would plan, chart out how telemedicine was going to be rolled out. We had a 2-year plan of rolling out a telemedicine platform. Some specialties had already started piloting it, but we didn't really have much experience with the platform we eventually chose. And I think what COVID did was it came as this huge wrecking ball, and I hate to say it this way, but it basically demolished all the bureaucracy and all the red tape that we were fighting with, both internally in our organization at that time and then externally everywhere. And it allowed us to create this new platform virtually overnight. So instead of having a 2-year plan, it all shrunk down to a 48-hour period. I remember I slept in my hospital one night, and I mean, it was just literally working from 7 in the morning, the moment you wake up, to 1 a.m., 2 a.m., back to our residency days, trying to tweak out every flaw, every little glitch in the system, trying to understand every regulation. What does HIPAA allow us? What is the new HIPAA like? What are changes? So the month of March was a lot of anxiety and a lot of I want to say excitement, and we would kind of just live within these two adrenaline extremes. And then April and May, things settled down. We got some understanding of what the new regulatory landscape looks like, and what does what CARES Act, the CARES 1 and CARES 2 actually mean. What does it mean for our staffing? How do we actually run a practice now? What do patients need? What do we want? What do consumers want? All of those things. We kind of got an understanding of that over the months of April and May. And then June and July have been great, because we've taken all that we learned, or at least I've done that, taken all that we've learned in the months of March, April, and May. And I say March, April, maybe for you guys on the East Coast, it started a couple of weeks before it started for the rest of us, right? I mean, I want to say for you, COVID really hit home in the end of February rather than early March like it did for us.
Well, COVID hit my home on March 6th. That's when we got all infected. So that's our landmark day. It's my sister's birthday actually that day, so I'm not going to forget that day. We won't go into my COVID stories. That we'll save that for another story. But February 18th is when I sent out an email to a text message, to a couple of my friends saying, hey, in a month from now, the stock market's going to crash, and something bad's coming. So stock up on paper towels and canned corn. And I got
we didn't get it in the Midwest. I actually feel so silly now. We didn't get it until, I want to say, at least the 10th of March. That's when it started hitting home. But the months of June and July and now early August have been great, because we've taken all the learnings from the first 3 months of this crisis and put them in their right place in the long-term perspective that we've all had about our organizations. We knew for a while that we'd be changing. We knew that we need to go towards value-based care. We knew that we need to go towards a telemedicine, here and now based care. We knew that our patients were changing in their demographics, right? We knew that we would age out of the baby boomer generation and go towards Gen Xers, and then more importantly, the millennials who'd want care in the palm of their hand. We knew all this stuff, but it never internalized until now. And now we have all the gadgets set up. We have all the tools set up. So now to put the 3-month crisis into the perspective of what the next 30, 40 years of healthcare would look like, we're beginning to think about growth again. We're beginning to think about how to leverage this experience and turn it into something positive. And that's what we're doing. So that's my overall big spiel of what the last 5 months have been like.
Yeah. So, in terms of change, it's, you said in 48 hours, everything was turned on its upside down and on its head. Couldn't agree with you more about that. You said you got to the hospital early and you stayed till 1 a.m. and it was just, again, exciting, but anxiety provoking and scary and, all these different emotions all at the same time. But this is why you won the Physician of the Year award. You found a problem and you went and you slept at the hospital until it was fixed. But I guess the coming months, we don't know what exactly is going to happen. In the coming months, the last quarter, last several months of 2020, who knows? Will there be a second wave? What will it be like? Will there be a vaccine? What's flu season going to be like? Are people going to wear masks? Will there be a new national strategy? Will things change if there's political changes, a new administration? or will something else that like will another virus come, God forbid? I mean, like, who knows? We know, all I know now is that we know nothing, and they do as well as they can try to predict. And I just wish we had, like, honestly, more paper towels, because like I literally we've been out of paper towels still, and it's like all these months in.
Yeah.
But I guess if whether a a solo practitioner, group specialist, an academician, from what you've learned in the last several months, are there any preparatory comments you have for getting ready for who the heck knows what's going to happen in the coming months? And in terms of, I guess the other thing I want to touch about, like the financial parts, I think a lot of us are struggling. I think most physicians I've spoken to, close friend is a radiologist, close friend is an allergist, close friend, a lot of subspecialty friends, and mostly neurologist colleagues and friends, obviously, but we're all suffering in some way, whether it's a financial hit and a major financial hit, whether it's great. We got the Paycheck Protection Program. My brother, for example, it really helped him. He was able to keep things going, but now we're realizing, wait, okay, that money, great, but what do we do here? Research trial revenues, the clinical revenues down, telemedicine, who knows if we're going to still get the reimbursements. I'd really love to talk about not just helpful tips about what we can do to prepare and expect, and maybe prepare way early before something happens, but what you see on the horizon for the financial piece too.
Sure. Yeah. So let's start with the first part. I think you've asked two questions, right? The first question is what have we learned? I like how you put it. You said all we know is that we know nothing. I'm going to take that statement and I'm just going to tweak a little word of it. And what I think is, all we know is that we knew nothing. I think we've learned a lot in the last 3 months. I think one of the things that we did right as things were calming down, and again, everything is still fresh, but I want to say somewhere in the end of April, early May, when we had set up our telemedicine programs, we had set up rules of how we'll actually see patients. We were beginning to toy around with opening clinics to allow about 10%, 15% of our patients back in, opening 10% of our imaging back in, distancing gaps between air circulation. We were learning about all that. One of the things that we actually did was we all took a week off from all this planning. And we said, we're going to spend time in writing down and archiving everything that we've done. So what we did was we took emails and we literally copied them into Word documents, gave the right folders. So what we ended up doing was in that week or couple of weeks, we actually created a whole binder, a whole online folder of what we had learned. How did we actually change every department? How does the supply chain change? Where did we actually eventually end up finding PPE? How do you actually, funny stuff. There was a time in our hospital when we ran out of needles. How do you run out of needles in a hospital? How do you actually find a second vendor to get needles when the supply chain has been disrupted across the board from China to, Southeast Asia to Germany to here? We learned everything about how our supply chains actually worked. It wasn't just about calling Cardinal and getting stuff delivered anymore. It was about figuring out how it's done. And so we wrote all that down. So one thing that I would say is very helpful, or I hope is helpful as we go into our second wave, third wave, second virus, third virus, vaccine arrival, vaccine failure, all that stuff, right? There's multiple possibilities that could happen. The second, I think what we should do is we should all create a paradigm of how to approach any of these possibilities. And as we have gaps in our already getting busier schedules, I think all of us should try to archive all that. We did present, the American Academy of Neurology organized this webinar that we presented, I presented at a couple of months ago about reopening. And one of the things that I shared there was our hospital systems paradigm, which basically creates a red, yellow, and green zone or green state of affairs. And the red, yellow, green are dependent on, number one, what is the amount of COVID spread in the community? And number two, what are our resources? How much PPE do we have? How much staff do we have? How much, all that stuff. So if you have a moderate amount of COVID spread, then it can be turned into a red zone if you don't have enough PPE, or into a lighter orange zone, or almost a green zone if you have plenty of PPE available. Mm-hmm. So you can actually tone it up and down depending on how much PPE and other stuff you have. So, but the point is, if you have a paradigm, whether you call it the red, yellow, green model that we use in our hospital system, or the state of Minnesota uses the dial up and down approach, everybody should have an approach that they used in the last 3 months, and take some time to archive it and write it down, and save all the policies that you created in a 30-minute period, because you don't have time to create a new policy for how EGDs happen now, or how needle electrode examination happens. How do we use you use paper tape now in an EMG as compared to using the regular old tape. But write all that down so that when it happens again, should crisis hit again, which we're all pretty sure that we'll at least see 1 or 2 more of these twists in the next year or so, let's say, then we're not caught off guard again. At that point, we don't go into this saying, well, we knew nothing. We should say, yeah, we learned the first time, and this time was 80% of the work was already done. So that would be one. That's the first part of your question. The second part of your question is what financial impact will COVID have on our practices going forward, right? Mm-hmm. And I'm going to answer that question again. I oversee a lot of medical specialties and musculoskeletal specialties. So there's surgical specialties involved. I won't talk about them, but neurology. There are every year, as you know, there's a new fee schedule that comes out, and the new fee schedule that has come out, at least for our US viewers, has already had been talking about and has done it this year. We've moved towards right sizing how cognitive specialties are reimbursed. So one of the things that cognitive specialties had been asking for was to be reimbursed based on time, and to value not just the time that we spend face to face with patients, but to actually value all the time that we spend before and after seeing a patient, and value that as well. And what has happened is that that is being rolled out as of January 1st. So that's the biggest thing that I would say neurologists should be prepared for, is the fee schedule change that's coming. And what's happening is that time-based reimbursement is going to be valued, which has always been an option, but it's going to be valued differently. So from January 1st, all the time that you spend in caring for a patient in the 24-hour period of the patient's visit, all of that time will be valued. So let's say if your patient's visit is at 10 a.m. and you went in at 8 and you started looking at your schedule, and you spent 6 minutes in looking at the patient, and then you spent 20 minutes in seeing the patient, and then you spent 10 minutes in doing the orders, and then you spend 5 minutes in calling the oncologist because your patient has MGUS and you wanted to go over that with them. And then you sent some labs which came back at 6 p.m. and you spent another 5 minutes calling that patient back. All of those 5 and 10 minute segments can now be added up. So that's a very positive change for cognitive specialties who spend a lot of time before and after patient care. So we must think about our practices and think about where that model would be useful. Not every patient should be seen that way. There will still be medical decision making, obviously, where you do something and there'll be procedural reimbursement. But again, we probably will spend a lot of time either late this year, if you want to be prepared, or early next year after this is rolled out, in reanalyzing how our practices are working. So that's the micro part of it. But the macro picture is that CMS in the last 10 years has spent a lot of time talking about the value of what we do. And we're going towards a model of value-based medicine. So what COVID has taught us is that we had an X amount of work that needed to be done. And we couldn't do it the way we always have done it. So we found new ways of doing the work. So instead of holding our ear this way, we kind of found a new way of holding our ear. But the point is, what Medicare has been asking us and what our consumers, our patients have been asking us is that we should do our job, not waste time in doing all the red tape that we do, and find new ways of doing our job. So on a broad set, think about that. Is that too vague?
Well, no, I mean, what I hear, well, so first of all, thanks for the details, and thanks for kind of going through it so seamlessly and, carefully. What I hear from you and kind of a gestalt is that you're more hopeful about the future of not just being able to be better prepared because of pre-preparation of learnings from the past, but I think you are more hopeful because, as you said at the beginning, we have an audience, we have a patient cohort that's changing, demographics are changing, they have specific wants and needs, and talk about millennials and about the zennials and Generation Z, and from on either side of the millennials, we have like everyone else that probably also wants this type of care. And I guess what I'm realizing is that, I mean, I think it's pretty effective. I mean, I don't know for sure. We need studies and research and all that kind of thing, but in some ways, we can reach more patients more frequently. We can, I have a every other week call with someone that that now we get reimbursed for calling. I mean, that's amazing. And we have a call, and if we can jump on the video, and we have just regular amounts of care. And then for time-based coding, there's so many more doors open to us. And I guess what I'm hearing from you is that there's a lot of hope on the horizon, and that maybe these very, very, very immensely challenging times, especially financially, at least maybe the ship will be able to be, a little bit more stable in the coming year or two.
I think so. I think that eventually what everyone wants to do, and when I say everyone, I mean physicians, I mean healthcare systems, I mean insurers who reimburse them, and most importantly, our patients, our consumers. What everybody wants is, we want healthcare to be delivered in a method that they want, the consumers want, right? And B, in a method that's effective, and C, in a method that's not wasteful. And what we've done in the last 20 years is, I don't know the history of Medicare and CMS in the 90s and early 2000s. I've started following it, in the last 15 years or so, let's say. But what I've seen is that everybody wants to take away, all of these different parties wants to take away bureaucracy and red tapeism and stop wasting time doing all that. And I think that we as physicians must also play our part in analyzing what we do wastefully and where we could do things more effectively and more, in a way that patients need and want it done. And that's what we're trying to build, is a model that's more patient-centered.
Yeah, and the things that we've been able to accomplish now, you said, of course, that a lot of the regulations were relaxed, from interstate ability to care for people, which kind of, how much sense does it make to not be able to care for, I mean, right? And, with HIPAA, and HIPAA has its challenges and benefits and all that, but, like FaceTime, if you need to talk to someone, like in the past, we couldn't really use FaceTime, but if that's the only resource available, so I think, this challenge, we talk about silver linings, it just got the bureaucracy, like you mentioned, just, the red tape was cut. I just hope that these, these realizations stick. I think, we were planning a couple months ago, well, the telemedicine reimbursements are going to run out in a few months. So, and I kept in the back of my head, I said, sure, and we should plan for that. But some of these, I think, are going to be here to stay. And, and then okay, we'll extend by a month, and then we'll extend by another month. I mean, do you think that, I guess the last question, do you think that either through government payers, Medicare, Medicaid, and private insurers, do you think that telemedicine reimbursement is here to stay, or do you think it's still just going to depend on the carrier and maybe not?
So that's an answer that's very difficult to give in definite terms, right? If you ask me, is it here to stay? We don't have that answer. We're obviously the American Academy of Neurology, and all of us individually, the Wisconsin Medical Society, those are the organizations I work with. They're working very hard on telemedicine parity. So we're all trying to figure that out. But here's what I feel, and in doing analysis over time, there's a couple of things to think about before answering that question. Number one, can telemedicine provide healthcare in a way that is needed, right? If you see a patient, can you see every patient effectively through telemedicine? And the answer to that question is obviously no. But can you see some of your patients through telemedicine? And the answer is absolutely yes. We've all learned through that. So number one, let's just think about it from a practitioner standpoint, right? We need to find effective users of telemedicine and be able to define them really well. The way we are working on, the way I am working on in my practice and also in our hospital, in our healthcare system, is that we've defined, we saw whatever X number of patients, right? We've got thousands, tens of thousands worth of patients' data, maybe hundreds of thousands of patient data sitting in our hands now. All of those patients form this big sphere of patients. And in them are three things to think about. Number one, which of these patients can be effectively seen? So if you can imagine a Venn diagram, one of those circles would be patients who can be effectively seen medically. That's one Venn diagram. The second circle is patients who want to be seen and who can technology-wise be seen effectively. So that's the second group. And the third group is, where will our payers be willing to pay? Generally, payers follow patients, right? Patients will sign up for insurers. Employers will sign up with a certain insurer if patients want that, right? So in any case, payment, which patients will be paid for, which kind of procedures can be done effectively, and the third, what kind of patients would want to be seen, whether it's the younger people or the people who live farther away from our clinics, or certain conditions like my migraine and seizure patients. I mean, they want to come in, they want to do this on telemedicine. Why do we want to miss a half day of work when you can simply, go to the parking lot and have a 10-minute phone conversation? So the overlap, the intersection between those three zones will define the patients who can effectively be seen with telemedicine. And as our capabilities grow, I believe that that intersection zone will keep growing. So do I believe that telemedicine will stay? Absolutely, it'll stay. We don't do anything in stores anymore. I mean, the last time I went to a store to literally buy a shirt was, I think, like 6 months ago. But I've got new shirts. I'm wearing a new shirt that I ordered off online, and it works out pretty well. So we're doing everything online. Why would we not do healthcare online? But we need to define the right patient. So that's the feasibility part of it. Will payers follow this? I think absolutely. When you look at payer data, most payers who come back to us and give us some feedback in my healthcare system tell us that telemedicine should cost anywhere between 45 to 65%. The AAN, I believe, is looking at data, and they're getting the same kind of feedback. But we spend less money doing telemedicine. The cost of your Manhattan office, the cost of electricity, the cost of all the staff that's required to run that, the fact that every cleaner, every cleaning chemical that we use, cleaning supplies that we use have to be regulated and be very, very well done. The cost of maintaining an office is quite expensive, and the cost of me sitting here looking at this iPad and talking to a patient is actually almost nothing at all. So the cost of providing telemedicine is lower. So yes, insurers, payers will want telemedicine. They'll of course want to pay us less. Right now we're in this hybrid model where we're all going to our offices and seeing half of our patients on telemedicine and the other half in real. So of course we're running our businesses just the way we do, but after all the dust settles and we figure out that we could probably spend a couple of days a week at home seeing our follow-up patients, and then we go to work and we spend a couple of days in clinic seeing new patients and seeing our challenging patients that cannot be seen with telemedicine, and doing procedures. Once all the dust settles, I believe that we will be able to bring down our cost of delivering care to match with the cost that payers think they should be paying. And until then, I think payers will overpay and we will under-receive, and somehow we'll make it work. But I think whoever can get closer will end up being the winner out of this crisis, and that's what we're hoping to do here.
That's great. Gurdesh, this is another one of those classic examples, a video recorded, proven example of the student surpassing the teacher. I learned a lot from you today. Thanks so much. I'm gonna say again, happy birthday.
Thank you so much.
29.9 again, right? I stopped there.
Is that right? Okay, got it.
29.9. No, I just add 9.999.
I don't deny the fact that I have I have some white hair. I love my white hair. I just wish I had some more of those.
I don't know. I mean, it's character building.
White beards are cool, so I can.
Where's your bow tie? You're missing the bow tie.
My bow tie, yes, that went away in COVID. I realized that again, bow ties are not required for providing healthcare. You can do that in a t-shirt just as well. So again, it's all about what do our patients need.
That's a great analogy. Absolute pleasure. Thanks so much. Enjoy.
Thank you so much for doing this. Yep. Have a good one.
Bye-bye.
Yep. Bye-bye.